Спасибо.
So today's lecture is actually focusing, as was introduced, on pearls and pitfalls of breast MRI, in particular, really getting into the details of breast MRI interpretation. I'm going to weave in some common challenges in interpreting breast MRI, but also the brand new BI-RADS lexicon that was just released, actually now called a manual because it is so big, no longer an atlas. And this is the 6th edition. It was published in December of 2025. And there were some changes, and I'm going to talk about them across all different breast imaging modalities, but also MRI. And so we're going to talk about the updated terms and what they mean. So let's jump right in. And, I'm starting with the basics just to get an even playing field for everybody. So typical breast imaging sequences for breast MRI. And then we'll talk about why we actually need them and what can we do with them. So in general, technical considerations, the recommendation for diagnostic breast MRI is to have at least a 1.5 Tesla magnet strength because that really affects our resolution and therefore interpretation. I will say that 3 Tesla magnets are much better. And in fact, in particular, these have been shown to be much more consistent with the extent of disease on surgical specimens than 1.5 Tesla. So 3 is more accurate than 1.5, but at least 1.5 Tesla is recommended. And that really affects resolution. In fact, with 1.5 Tesla, we overestimate the extent of disease, not under, we actually overestimate. And the 3T magnets allow us to truly define the extent accurately, a millimeter to what the surgical specimen is. But we work with what we have. Pre-contrast phase images should be acquired before the administration of contrast, and you need a dedicated breast MRI coil. Currently, the breast MRI coil is done so that the positioning is in prone, so the patient is lying on their stomach. The breasts are hanging down. They are not compressed, with a dedicated coil to image the breast. In fact, right now, just as an aside, there is an investigational study looking at a supine breast coil from GE. So one where patients could be lying down on their backs. It's still in investigation. We're working on it with GE at Cornell, just so you know. Eventually, it'll probably come to fruition, but right now, all of them are prone. So some of the first images that are obtained by the technologists are the localizer images. Usually they're obtained by the technologist to just ensure, it's basically a scout image, like on CT, like an X-ray, to ensure that they are covering the entire extent of the breast. That's why the technologist is doing it. It's usually performed, and it should be performed in 3 planes, so axial, sagittal, and coronal. And it will also include some areas of the upper abdomen that are not included in your field of view on any other sequences. But remember, as a radiologist, everything that's on the images, you are responsible for. So it is very important to review these images very carefully. And I look at them just for things outside of the breast. So this is an example of a recent patient. This is just a localizer image, and you can see there was a mass in one of her lungs, ended up being an incidental lung carcinoma that I was able to diagnose or note only on these localizer images. Have noted in particular metastases in the spine that you may not see them in the field of view of the other images. So you are responsible for all of the images, so definitely review the localizer carefully, and do not look at the breast here. Just look at everything else. That is what it's for. The next sort of set of sequences are T1 weighted sequences before contrast is administered, and these are not fat saturated. Fat is bright, so this is fat. here. And this is a good sequence for a couple things. One, it's good to determine the amount of fibroglandular tissue. So as we talk about density on mammography, we also have to report fibroglandular makeup of the breast on MRI. And here it's similar, akin to a mammogram. So it's easy to interpret it and really assess the amount of fibroglandular tissue on these sequences. It's also very helpful in problem solving when you see a mass and you're trying to decide, is this a mass or just a normal benign intramammary lymph node? This will help you. I go back to the sequence to look at the fatty hyla because you'll see the bright little center in a reniform kidney-shaped mass. You know it's just a normal lymph node. You can let that go. It's also helpful for evaluating fat necrosis. So in breast cancer, usually there's no internal fat, unlike, liver cancer and so on. So if you see an irregular mass with rim enhancement on the other sequences, that's very concerning. That could be an invasive ductal carcinoma. But go back to your T1 weighted images that are not fat suppressed. If the center is T1 bright, that's just fat necrosis, and you can give it a BI-RADS2. It's also very helpful for visualizing localizing clips. So if somebody had a biopsy and you're trying to see where is that clip, where is it? There is a blooming artifact on these non-fat suppressed sequences. So it's much easier to identify the clip on these images than all the rest. So then you can put your localizer on it and look to see if there's any abnormal enhancement, et cetera, on the other images. So this is what this sequence is very helpful for. So you can see the clip here. All right, this is just an example of fat necrosis as I was discussing. So you can see here on sagittal images, there is a mass with rim enhancement. May be suspicious. You may question, what is this? But then when you look at those non-fat suppressed T1 pre-contrast images, first of all, you see susceptibility artifact. She had surgery here. This is from surgical clips and sutures. And then you see that internally, this whole mass is all fat. This is just benign fat necrosis, and probably on the mammogram, sometimes it's evolving, so it may be not as mature, but here it was a good example and correlation of beautiful BI-RADS2 benign fat necrosis in that area. But if you didn't have it or it was early on, you'll see these findings first on MRI. So this is a really helpful problem-solving sequence that is indeed very helpful, in particular to assess your irregular rim enhancing masses, which we'll talk about later. And then fluid sensitive sequence. So it's a T2. Some use STIR. What is it helpful for? So to evaluate for benign cysts, lymph nodes tend to be very T2 hyperintense. Seromas, so fluid after surgery. And now it actually has been incorporated as a required descriptor of masses, whether they are T2 hyperintense or not hyperintense. And we'll talk about that later. So that is what we look at. But another thing that I find the sequence to be very helpful for, and I look at it next, I just scan through the STIR images up and down, not looking necessarily at the breast, is to look again outside the breast, in particular at the bones. So one of the first signs of osseous or bone metastases is edema in the osseous structures. This was a patient of mine after bilateral mastectomy for right breast carcinoma. The breasts were actually fine, but unfortunately, she had multiple areas of metastatic extent now, with a recurrence that was metastatic. But I first noticed it, and it was much easier to really detect on these T2 weighted STIR images where I saw the abnormal T2 high signal in both her sternum. And actually, I'm not showing all the sequences, but in multiple ribs. And this was metastatic carcinoma, which you could see the enhancement later on the post-contrast images, but it was very, very subtle, pretty faint. It's the T2 signal that really shines through, that helps you detect. So my order of interpreting MRI, again, just to go through it, I go through the localizer, looking at everything that is not the breasts to make sure there's not a big cancer somewhere or a finding. Otherwise, I look at the non-fat saturated T1 weighted sequences to assess for fibroglandular tissue and then report it. And the sequence also is used for problem solving later. And then I look at the T2 sensitive images to go through the rest of the MRI up and down, predominantly looking also outside of the breast, looking to see if there's any abnormal edema or findings that I later need to assess on subsequent images. These are just example of some of the cysts that you can see in the breast, just benign. And this is a tiny lymph node. You can see it's T2 hyperintense. And here on the non-fat suppressed sequence, you can see the little notch that is the fatty hilum that this node, intramammary node, has, and also usually has a little branch of a feeding vessel. And this is just a postoperative seroma, normal, benign. It should enhance very, very smoothly in a smooth rim enhancement in a circumferential fashion. If there's any irregularity or thickening to the enhancement, then you start questioning residual disease, and we'll talk about that later as well. All right, so then we actually get to the meat of the MRI sequences that actually allow us to detect breast cancer. So post-contrast sequence is what allows us to detect carcinoma. As we talked about in the prior lecture, this is really the most sensitive tool we have for the diagnosis of breast cancer, with sensitivity approaching 100%, because the basis of this idea is that cancer requires vascularity to grow beyond about 2 millimeters or so. And so anything that takes up contrast, that's all you're looking at, can alarm you to it being a cancer. Of course, as we'll talk about, lots of benign things also take up contrast because it's an organ and it has vascularity, and we'll talk about how to differentiate the two. So we remember we obtained pre-contrast images, and then when we obtained post-contrast sequences. For a full protocol breast MRI, you need at least 2 time points after injection. So usually you obtain the first sequence around 90 to 120 seconds after the injection. And then when it's done, an additional sequence, at least one more, is obtained. That is considered for full protocol. You can have multiple other sequences, but if there's less than that, then it's considered abbreviated MRI. Because you have a pre and a post subtracted image, or pre and a post contrast image, the most softwares, your technologist or you yourself, can create a subtracted image of the a subtraction image, which will show you only T1 brightness for anything that takes up contrast. So that subtracts anything that was inherently T1 bright on the pre-contrast images, like blood or protein. Then you know if it subtracts out, it is not enhancing, it is usually not concerning. And then you can utilize the maximal intensity projection image, which kind of gives you a 3D view of both breasts. And I usually look at it on the subtracted images. I use the MIP reconstruction on the subtracted images to give a roadmap and an overview of what the breasts look like. So that's just sort of the basics of breast. Now let's talk about actually what you're looking at, how to troubleshoot, and how do you report breast MR. So one of the first requirements, as we addressed, just like on a mammogram, is to report the fibroglandular tissue composition. Fibroglandular tissue is defined as the non-fatty, non-cystic breast tissue. You can look at the T2 weighted images, or as I showed you, the T1 weighted non-fat suppressed images will show you basically the composition. Just like on a mammogram, it's your subjective assessment of how dense they are, basically. And you define them in quartiles. Is she predominantly fatty? Less than 25% of the breasts have fibroglandular tissue. Is there a little bit more scattered, heterogeneously dense, or extremely dense? Same really categories as on mammography. The exception here is because, remember, on MRI, what we're looking for is enhancement. Density does not obscure your ability to detect things. So you do not need to put in that phrase of breasts are extremely dense, which can, obscure small masses, because that is not true in MRI. You will just say extremely dense or extreme fibroglandular tissue, and that is what you're reporting. So this is just the 4 categories on MRI. These are, again, the T1 pre-contrast, not fat suppressed images. And you can see this is where you assess from fatty, scattered, heterogeneously dense and extremely dense, and that is what you report. Because remember, that also goes into the patient's risk assessment of her lifetime risk of breast cancer, as these patients are at elevated risk, and these are the mammographic correlates for these patients. Again, just the sort of the continuum of fibroglandular tissue composition. So that's fibroglandular tissue. What then MRI has that other modalities do not is background parenchymal enhancement. And so what does that mean? Background parenchymal enhancement, right, as we talked about, lesion detection at contrast enhanced MR depends primarily on its vascularity and therefore enhancement, or T1 brightness, relative to normal breast tissue. Diagnosis, and we'll talk about that later as well, primarily depends on morphology, right? So abnormal, irregular morphology increases your suspicion. But the thing is, normal breast tissue can also enhance, and that is what's termed background parenchymal enhancement. And so that is defined as the volume and intensity of the fibroglandular tissue enhancement. You can look at it on, usually you're supposed to assess on your first post-contrast weighted images, whether subtracted or not, to assess how much of the tissue enhances. It's the proportion of the amount of tissue that enhances. So this is an example. These are maximal intensity projection images of 4 different patients on the first phase subtracted images. So that's what I created the MIPS from. And as you look overall at this breast, there's very little enhancement. So this is minimal, less than 25%. This is more scattered. This is moderate. And this is basically all of her breasts bilaterally enhanced. Also notice, and we'll talk about that later, there is symmetry to her background parenchymal enhancement. Both breasts enhance symmetrically. That is a sign of benignity. There are exceptions where asymmetric enhancement can still be benign, which we'll talk about. But in general, symmetry is your friend, and that's a sign of benignity. But again, again, this is just, again, an example from minimal enhancement to mild to moderate to marked. And you can imagine, why does this matter? So there's multiple reasons why this does matter. But one of them is that, remember, you are trying to assess and look for a cancer in the background of this normal enhancement. So it might be much more challenging to pick out a cancer in somebody who has this marked background parenchymal enhancement. It could be hiding in here. Also, you can mistake some of the areas of this marked background parenchymal enhancement for a cancer and recommend ultimately unnecessary biopsy. So background parenchymal enhancement can complicate and challenge our MRI interpretation, and we'll talk about how to address it. But one thing to remember, and this is going back to the assessment, is that background parenchymal enhancement is the proportion of mammographic density composition that enhances. There is no correlation between BPE and mammographic breast density. Just because somebody is extremely dense on a mammogram doesn't mean they have marked background parenchymal enhancement. So here's an example. This is a woman who is extremely dense and has minimal background parenchymal enhancement on her MR. This is, again, a woman that is extremely dense mammographically, and only a small proportion of her tissue actually enhances. And you can see multiple little focal areas of enhancement. So this is mild to moderate BPE in a woman with extreme fibroglandular tissue. Conversely, this is a woman with scattered fibroglandular tissue on mammography and also on MR, but all of this tissue enhances. So she has marked background parenchymal enhancement. So the way to think about it is, let's say, very simply, if somebody has 100 fibroglandular elements and 10 of them enhance, right? That is minimal background parenchymal enhancement. If somebody has 10 fibroglandular elements and 10 of them enhance, that is marked background parenchymal enhancement. Same amount, but it's proportional to their fibroglandular tissue, okay? And again, why does it matter? Oh, sorry, it keeps jumping. Because one reason is that it really complicates our read. It can increase unnecessary follow-up and biopsy recommendations, complicate our reading, because both areas of, so focal enhancement, masses, and foci actually now is out of the lexicon. And areas of linear non-mass enhancement can all present as background parenchymal enhancement. So you can mimic cancer, and it can obscure underlying cancer. So here's an example. This is actually a patient, 68-year-old, with a biopsy-proven invasive ductal carcinoma. This was mammographically and sonographically detected. This was her cancer in the right breast, retroareolar breast, and then she underwent an MRI for extent of disease. And this is multiple sequences of her MRI, and you can appreciate there, and this is on the first phase, she has marked enhancement of both breasts, and you see multiple masses bilaterally. So is this all cancer bilaterally? The answer is no. So because you do appreciate the symmetry of it, so you have multiple similar appearing masses in both breasts, you have areas of focal non-mass enhancement symmetric in both breasts, that this is all benign. But you can see how this could really challenge, and you can question each one of these masses, is this suspicious? Also, where is her actual cancer? It's very challenging to appreciate. So again, we went back to the non-subtracted images. You can go back to the non-fat suppressed images to look for that clip artifact. That sequence is very helpful because then the clip blooms. This is her biopsy-proven, or this is the marker at the site of her biopsy-proven cancer. It was quite small. There's hardly any associated enhancement here. So it could both have fooled you in thinking that some of these are cancers and potentially obscure a cancer as well. The other reason, sorry, it keeps jumping, that background parenchymal enhancement is very important is because it is an independent risk factor for future development of breast cancer. So there are multiple studies and now meta-analyses that demonstrate that women with breast cancer tend to have much higher background parenchymal enhancement compared to control participants. And so you could look at these studies. And the reason behind it is really the fact that of what controls background parenchymal enhancement. And those are two things. One, which we'll talk about in a second, is really the anatomic distribution of the vessels that supply the breast. And two is the hormonal milieu. So background parenchymal enhancement is affected by how leaky the vascularity is that feeds the breast, and also where that vascularity is located. And again, it represents just normal physiologic hormonal enhancement. So estrogen, in fact, causes hyperemia, so dilation of the vessels, and actually causes capillary leakiness. So the higher the estrogen level, the more background parenchymal enhancement you will see, because the contrast will leak out of the capillaries and the vessels much faster. Progesterone actually on a monthly basis causes angiogenesis. So there's more vessels that are created. So again, increasing your BP. As such, you can imagine the higher the estrogen, the progesterone, the higher your background parenchymal enhancement will be. So in a woman that is postmenopausal, your BP is going to be lower. In a woman who is treated with anti-estrogenic medications such as tamoxifen, the BP will decrease. And at certain points in the menstrual cycle, the background parenchymal enhancement will decrease. So why does this matter? In addition to interpretation, you know that a risk of breast cancer is directly related to the level of estrogen and progesterone in the woman's body, both the duration of the extent and the amount. This background parenchymal enhancement is essentially a surrogate marker for how much estrogen and progesterone the woman is exposed to. So that is why this is an independent risk of breast cancer development in the future. And in fact, and we'll talk about it in a second too, it's also a great prognostic tool in how well a woman will respond to chemotherapy, in particular anti-estrogenic drugs. So if a woman has high background parenchymal enhancement and you put her, let's say she has LCIS, right? And so you are treating her with chemo prevention with tamoxifen. If her background parenchymal enhancement decreases, you know that tamoxifen is doing exactly what you want it to do, which is blocking estrogen receptors in the breast, the specific ones in the breast. And so that actually speaks to how well she will do in not developing breast cancer. So this is actually a very helpful metric in these patients for our oncology colleagues. But because background parenchymal enhancement does fluctuate during the menstrual cycle. In fact, happens to be lowest at day 7 to 14 of the menstrual cycle, day 1 being the first day of the menstrual cycle. So basically a week after menstruation. For a very long time, it was recommended that the optimal time to image may be for a woman that's coming in for just screening at day 7 to 14 of the menstrual cycle. And we'll revisit that in a minute, as that has been sort of fallen out of favor anymore. The other factors, of course, that influence background parenchymal enhancement is just where the vessels are located. So the arterial and venous anatomy of the breast is peripheral. The arterial supply is dual laterally from the branches of the thoracoacromial and thoracic artery, and from the cutaneous branches of the intercostal arteries, and medially they come from the internal mammary arteries. So most of the background parenchymal enhancement therefore begins in the periphery, and the tissue becomes slowly, gradually more apparent, or enhances slowly as it diffuses in the center. The venous supply follows arterial, so the reverse is true too. First, all of the contrast or the background parenchymal enhancement leaves centrally, and lastly, will it diffuse out into the veins peripherally. And so one of the most common patterns of background parenchymal enhancement, which is benign and therefore should not alarm you, is called picture framing, where you see areas, either masses or areas of non-mass enhancement, again, foci are now out, that really take up the contour of the edge of the fibroglandular tissue, predominantly laterally, because remember, we have two dual supply laterally, and then also medially, superiorly, and inferiorly. And you can see they really just highlight the periphery of the tissue called picture framing. This is benign BPE, Barrett's 2, no reason to mention it. Again, another example of picture framing here, sort of catching it at the very tail end, and you see this enhancement. You may question it. Oh, is this just non-mass enhancement? Why is it on the edge? But as you assess and look at both breasts and the remainder on the sagittal, you see that you're seeing this enhancement, non-mass enhancement, really outlining the contours of the fibroglandular tissue. This is normal BPE, picture framing. BPE can also be made up of little masses, as you see here. This was an example I showed you earlier of marked background parenchymal enhancement. You see multiple masses, but they're all really outlining the periphery, making it a picture frame. This is benign, Barrett's 2, just normal BPE. So this is an example of the hormonal effect of background parenchymal enhancement. This was a woman who came in for a regular MRI, and happened to be during the 4th week of her menstrual cycle. It was thought, you see enhancement in both breasts. It was thought to be asymmetric on the right side, so a little more on the right side. So this was questioned as potentially being clumped non-mass enhancement, but still thought, because of the similar morphology, thought to look very similar to the other side. So 6-month follow-up was recommended. Biopsy could have been recommended as well. This is sort of on the edge here because of the asymmetry. When she came back, we recommended she comes during that 2nd week of the menstrual cycle. So she came on day 7, and you see that all of that enhancement is completely gone. So she has minimal enhancement during that 2nd week of the menstrual cycle, when estrogen, progesterone influence the breasts the least, and therefore your background parenchymal enhancement is at its lowest. And so here, similarly, you can see if you, in another helpful way to ascertain if something is background parenchymal enhancement versus something suspicious, is if you have serial examinations. So background parenchymal enhancement tends to wax and wane, and you can see this is one MRI, this is 6 months later in the same patient, and she has these multiple masses that are scattered everywhere. Because they were in both breasts, there was no concern. We called it background parenchymal enhancement. But you can see that 6 months later, all of these are gone, but similar appearing new masses are in a different area, again, scattered. So you see areas of waxing, waning, similar appearing background parenchymal enhancement over multiple serial exams, if you have them. And that is another sign of benignity of just normal background parenchymal enhancement. There's another woman who came in and she actually had newly diagnosed breast cancer on the left side. We looked at her right and saw this area of focal clump non-mass enhancement. This was deemed suspicious. And so she was recommended to come in for an MR guided biopsy because we didn't see MR guided biopsy on that side. She happened to come in during her week 2 of the menstrual cycle, and that entire area of non-mass enhancement is gone. It was just her background parenchymal enhancement. So really, there's a significant hormonal influence on background parenchymal enhancement. So, you know, previously it was recommended and consistently that all women, if it's a screening MRI, not for extent of disease, the woman's not waiting for surgery because you don't want to delay those, which come in during day 7 to 14 of the menstrual cycle, because that is when BP is the lowest, and therefore our false positives and false negatives are going to be the lowest. Since then, with newer studies, it has been suggested that higher abnormal interpretation rates in cases within although we have a higher rate of false positives in patients with BPE, it does not compromise our ability to detect a cancer, meaning our cancer detection rate does not decrease in the setting of BPE. From that, and this is some of the studies, the recommendation is maybe no need to necessarily adhere to that day 7 to 14. Having said that, the studies that were done demonstrating this were done in centers where there were a lot of priors for comparison. When you have multiple priors for comparison, it's much easier to dismiss something as background parenchymal enhancement because you can see the patterns coming and going, and therefore really hone in on what is new and abnormal, such as a cancer detection. So just keep that in mind. It is not required for you to schedule women day 7 to 14 of the menstrual cycle. Certainly, it's much more important she comes in for that MRI than limit her timing and schedule. But if you have the luxury of timing, definitely in premenopausal women, day 7 to 14 is much, much better. So let's return to other common patterns of background parenchymal enhancement. So as we discussed, picture framing is one, just based on the anatomy. And in general, anything that is bilateral and symmetric is going to be BPE and is going to be benign, regardless of morphology and regardless of distribution, as long as it's multiple, and multiple requires at least 3, just like multiple bilateral masses, and at least 1 in one breast. So here you see multiple little focal areas of enhancement. Now we don't call them foci. So if you only had one of these, you would question it, but now they're bilateral, they're scattered everywhere, normal BP. This is not much of a clinical dilemma. Here though, if I were looking at just this sequence and I saw this area of focal non-mass enhancement, this is worrisome, sort of not quite a mass, focal clumped non-mass enhancement. This should be biopsied if you just see this in isolation. But as I scrolled up and down her breast, I see multiple similar areas of clumped focal non-mass enhancement bilaterally. So now you have multiple. This is BPE. You're not going to biopsy all of them bilaterally. This is just her normal background parenchymal enhancement, and this is how it is represented in her breast. So how do we distinguish cyclical changes from malignancy? Again, look for multicentricity and look for symmetry between both breasts. And if you have the luxury of priors, look for temporal and resolvable patterns. So things that come and go over time. But and we'll talk about this too. So that is just overall. Things to consider as you're also interpreting background parenchymal enhancement, and that is the effect, because we know it's hormonally mediated, as I just touched on previously. So if somebody is on hormone replacement therapy, your background parenchymal enhancement is going to increase, but it's going to increase in a symmetric distribution. So that should be reassuring. It shouldn't be a challenge in interpretation because it should be symmetric. And as I mentioned, endocrine therapy with anti-hormonal treatment should decrease BPE, but it doesn't decrease it in all patients. So in those patients where it does not decrease, that's something to mention in your report, because that's a sign to the oncologist that it's not actually being or working well for this particular patient. Usually the drop in background parenchymal enhancement with anti-hormonal treatment or chemoprevention is seen usually very early in the treatment, usually about 90 days, within 90 days of treatment. If the anti-hormonal treatment is withdrawn. So it used to be recommended that tamoxifen was only given for 5 years. Now we're extending it. But if for whatever reason, let's say a patient couldn't tolerate because of the side effects and no longer gets tamoxifen, you will actually see a rebound effect of tamoxifen being withdrawn with a huge increase in background parenchymal enhancement. That should not alarm you. That is not a cancer. If it's, if you have a question about it, you can follow it up in 6 months and then it should calm down. But in general, it will be a symmetric bilateral increase in background parenchymal enhancement, even in a postmenopausal woman, because you just withdrew the anti-hormonal treatment. So that's something to be aware of. So history really matters and helps your interpretation. So here's an example. This is a woman who had carcinoma in the right breast. You can see bilateral, pretty moderate background parenchymal enhancement in both her breasts. This was the cancer. She then underwent a lumpectomy and was also put, because this was ER/PR positive, was put on tamoxifen. And you can see a significant reduction bilaterally, so also the other breast, because this is systemic, in her background parenchymal enhancement. Here is that same woman in 2010. She was on tamoxifen, hardly any, maybe mild background parenchymal enhancement because she has extreme fibroglandular tissue and very few of them enhanced. So this is mild at most. And then this was back in 2015 when they actually stopped tamoxifen after 5 years. After treatment, you see marked background, diffuse background enhancement, which then resolved 6 months later. But this is common to see. And again, you'll see this bilaterally and symmetrically because this is a systemic medication. And again, as I mentioned, because it truly speaks to how well the medication is working and blocking your estrogen receptors, the decrease in BPE actually correlates with improved tumor response and decreased recurrence rate in patients on anti-estrogen chemotherapy. So we talked about symmetry. Symmetry is your friend. It means benign. It means background parenchymal enhancement. But you can have asymmetric background parenchymal enhancement that is still benign if you have certain specific history. So in particular, after breast cancer treatment, there's due to radiation that is usually done post-lumpectomy for invasive ductal carcinoma. Because there's decrease in vascularity, in particular in small capillaries, that leads to decrease in background parenchymal enhancement in the affected breast. Sometimes you can see a decrease in BP in the contralateral breast if she's also on anti-estrogenic medication. But in general, you can appreciate this asymmetric background parenchymal enhancement after radiation. So if you just had this MRI and you had no prior history, you see there's multiple areas of focal non-mass enhancement throughout the right breast. There's hardly any, if any at all, in the left. If you see this and there's no history of prior radiation, this is concerning. This could be diffuse DCIS. You would question this. If there's nothing on a mammo or an ultrasound, you would do an MR guided biopsy of the most prominent area. But patient had breast conservation therapy and radiation of the left breast, which actually explains the reduction in BP on the left. So it's not that there's an increase in BP on the right, it's there's a decrease in BPE on the left. And this is her pre-treatment MRI. So again, this is the maximal intensity projection images, subtracted images. And we looked, and this is actually a good example of looking for things that stand out. So background parenchymal enhancement is multiple bilateral symmetric similar areas. And you can see them here, multiple focal areas of non-mass enhancement, or masses, whatever you want to call it. But these two stand out. They're bigger, they're brighter, and are much more avid in their enhancement, and maybe even questionably irregular here. That is not multiple, that's 1 and 1. That's unique. And so both appropriately were recommended for biopsy. This one on the right ended up being benign. It was just metaplasia. The one on the left was atypical ductal hyperplasia, which when it went to surgical excision was upgraded to DCIS, and it was actually high grade. So she did have, in addition to lumpectomy, radiation on that left breast. And so now you can appreciate that the background, the sort of the focal enhancement on the right is just the same enhancement she had prior to radiation on the right, and is just decreased on the left, and that accounts for the asymmetry. So that history really helps you dismiss this as BI-RADS 2 benign asymmetric BP because of treatment. So that's important to be aware of. Okay, so again, to summarize, for background parenchymal enhancement, to correctly assess background parenchymal enhancement, use the first set of plus contrast images. Spend some time and really practice and learn. Look for multicentricity and symmetry. If you have multiple priors, great. Look for temporal and resolvable pattern. Remember that background parenchymal enhancement carries prognostic information, right? So if she has high BP, she probably is at an elevated risk. This is something to mention, but also if the response of BPE to medication actually has prognostic information, carries prognostic information for patients' treatment course. So that's background parenchymal enhancement, which you need to assess and report on MRI reporting. And now in the last few minutes, let's just talk about what are the findings when we actually look for cancer and what are the descriptors utilized, what's suspicious and what is not. So previously, prior to the last issue of the last BI-RADS manual, we had 3 potential findings on MR, which was focus, mass, and non-mass enhancement. Now a focus has been completely removed, and we only have 2 options, mass or non-mass enhancement. The focus was removed because almost now that we have enough data, we know that almost all tiny dots of enhancement are benign and should appropriately be dismissed. And focus was really created back in the day when our magnet Tesla strengths were lower. And so anything below 5 millimeters, we could not appreciate and describe the morphology. We didn't have the resolution to describe the shape and the morphology. Now, with 1.5 and 3 Tesla magnets, we really can. And so we can now, this finding here previously would have been, it's 4 millimeters characterized as a focus. Now you can characterize this as a mass, and you would call this, and we'll talk about it, round in shape with rim enhancement. So you really can appreciate both the morphology and an internal enhancement pattern. So now let's talk about masses. First thing that you would describe is the shape, just like you would on an ultrasound or a mammogram. The new BI-RADS lexicon terminology that was added across all modalities is lobulated as a shape. And so you have 4 options: oval, lobulated, round, and for malignancy, least suspicious to most suspicious. Lobulated really implies 2 or 3 little lobulations or undulations. So here's an example. This is this is an oval mass, right? This is a mass that is round. This is definitely quite irregular in its shape. Then we discuss the margin, just like you would on an ultrasound and a mammogram. And really, your options are circumscribed or not circumscribed. Under not circumscribed, there's 2 other descriptors, but at the end of the day, the only thing that matters is it circumscribed or not. If it's circumscribed, more likely to be benign, although certainly, especially triple negative cancers and BRCA1 patients tend to be circumscribed in oval masses. But in general, circumscribed is more reassuring, not circumscribed is more concerning. And then under not circumscribed, if you want to get very fancy, you have 2 options. Either the margins are indistinct or spiculated. Previously, the margin name was irregular. They appropriately replaced it with indistinct because irregular is actually a shape of a mass, not a margin. So the new lexicon replaced irregular margin with indistinct or spiculated. So here's examples of well-circumscribed mass right here. This is a not well-circumscribed mass, right, with indistinct margins. And this is a not circumscribed mass with spiculated margins, pretty akin to mammography. And this is, again, an example of indistinct, so hard, more challenging for you to find exactly where the enhancement ends and to draw the margin. That is a new margin that replaced irregular. Then, so we talked about shape, we talked about margin, so shape, oval, lobulated, round, or irregular, margin circumscribed or not. Now we talk, and that's sort of the extra level that MRI provides, about the internal enhancement pattern of this mass. And again, going from least suspicious to most suspicious. Homogeneous, dark internal septations, which we'll talk about in a second, heterogeneous internal enhancement, and thick rim enhancement. Previously, it was just rim enhancement. Now it's called thick rim enhancement in the new lexicon. So this is a mass. It's oval. It's actually well circumscribed. Its internal pattern is homogeneous enhancement. This mass is irregular, not well circumscribed, with either spiculated or indistinct margins, and it's heterogeneously enhancing. There's multiple areas that are not quite, some enhancing more than others. And then this mass is round, you would argue, not well circumscribed, and you have thick rim enhancement. So those are sort of, any one of these, by the way, can be cancer. This one, least likely, right? But still can be, depending on the patient. This is an example of an oval, well-circumscribed mass that homogeneously enhances, but with these non-enhancing septa. When we do see that, that is highly suggestive of a fibroadenoma, with non-enhancing septa being sort of the stromal core of the fibroadenoma. And in fact, in this particular patient, went back and looked under an ultrasound, we saw an oval parallel mass. This was new, so this did undergo a biopsy and ended up being just a fibroadenoma, which corresponds to this mass here. But usually they're oval, well circumscribed with these non-enhancing septa that is highly suggestive of fibroadenoma, and they tend to be T2 hyperintense otherwise. So thick rim enhancement, I mentioned it, that's that last descriptor, most suspicious for carcinoma. Previously, they just called it rim enhancement. Remember, when we talk about very thin, uniform rim enhancement, they can draw with a tiny pencil. Look for, it could be a complicated cyst. It could be a hematoma. It could be a seroma postoperative. But when you start seeing thick or irregular rim, you start worrying about it being a malignancy, either residual, if it's a seroma, or new right here. And the reason rim enhancement is really most suspicious, because usually it indicates central necrosis and a mass that's growing so quickly that it's outgrowing its vascular supply and only peripherally enhancing. This can be, remember, one more thing, and that is fat necrosis. So because fat necrosis, as the calcification, the granulation tissue evolves, it can be irregular in how it forms. It has a lot of vascularity peripherally as the body tries to ward off the fat necrosis. So go back to your T1 not fat suppressed sequence. If this internally all is fat, it's much more suggestive of fat necrosis, and you may be able to follow it rather than biopsy this or say this is a carcinoma, especially in a patient who had history of surgery in that area. Okay, and then a new addition that is actually required for, now previously we just sort of did it off and on, but now required as part of the descriptor of the mass is whether it's T2 hyperintense or not hyperintense. And so that assessment is subjective. If something is T2 hyperintense, it needs to be T2 hyperintense uniformly throughout the mass, bright as a normal appearing lymph node. So quite bright lymph nodes are very, very, very bright on T2. And if you have T2 hyperintensity and the other morphology of the mass is reassuring, such as oval and well circumscribed, it favors benignity. Not 100%, but less than 2% likely to be malignant. So it's something that can potentially be followed rather than biopsied. The one exception I will warn you is, again, BRCA1 patients tend to make cancers that are very fast growing, triple negative, and they look like benign fibroadenoma. So if a patient's high risk, I err on the side of biopsy, then follow up, especially on MRI. Okay. That was masses, one category. The only other category is non-mass enhancement. So for non-mass enhancement, we talk about its distribution. So non-mass enhancement is something that you kind of want to call a mass, but you just can't quite see it in all three dimensions, right? So it doesn't quite has those convex margins, akin to something like an asymmetry on mammography. So what we talk about when we talk about non-mass enhancement is its distribution. Again, going from least to most suspicious: diffuse, regional, focal, linear, and then segmental. Usually non-mass enhancement, if it's unique, and again, we're looking for things that stand out, not bilateral, not symmetric, but unique, is a sign of DCIS, ductal carcinoma in situ. Areas or patterns of distribution can be concerning. However, if the ones that are most suspicious are linear and segmental. Segmental is like a little triangle pointing towards the nipple. And when you do see DCIS, about up to 77% of the time, it's in a segmental distribution because it's basically that ductal distribution pointing towards the nipple. Linear is in a line, but doesn't necessarily conform to a duct or point towards the nipple, just a line. And then I'll show you images of focal, regional, and diffuse. So this is an example of segmental non-mass enhancement. And you can see it's kind of a triangle that is pointing, especially on the sagittal, you can appreciate pointing towards the nipple. So this is concerning. This is linear, so definitely in a line, but not necessarily the nipple is kind of down here, not necessarily pointing toward the nipple, still suspicious. This is focal, it's just this kind of area of non-mass enhancement. It's quite small, and it's just kind of like somebody threw a little bit of paint or sand on the image, right? It's a little bit of focal non-mass enhancement. And then this is regional. So you see almost a delineation of the entire outer hemisphere. So it's not in the inner hemisphere, but it is in the outer hemisphere. This is regional. This is still concerning, and diffuse, involving the entire breast. So again, going back to background parenchymal enhancement, if you just saw this, right, this is asymmetric diffuse background parenchymal enhancement, only in the right breast. This is very concerning. This could be diffuse DCIS. This requires a biopsy unless this patient had radiation on the left breast, then it's likely or normal background parenchymal enhancement. So history does matter. Okay, so that's the distribution. Then we talk about the internal enhancement pattern of the non-mass enhancement. Homogeneous, heterogeneous, clumped, and clustered ring. And so look at examples here. And so the one that is most suspicious in actuality is clustered ring. Clustered ring refers to enhancement of abnormal periductal enhancement of abnormal ducts. It's just we haven't seen enough to say how frequently do we see it in the context of DCIS. But when you do see it, its predictive value for DCIS is over 96%. So if you see clustered rings, this is a BI-RADS 5. And I'll show you some examples. But that aside, because you don't see it very frequently, of the other three patterns, the most suspicious is clumped. And it looks like little cobblestones in Europe of enhancement in whatever distribution that you may see it. And then homogeneous and heterogeneous speak for themselves. So here's going back to that case of linear non-mass enhancement, that you can see these little patchy areas, like almost little, if you zoom in, little cobblestones on the streets. And that is termed clumped non-mass enhancement. This was biopsy proven DCIS, not surprisingly. And this is an example of multiple examples of clustered ring. So this is in a regional distribution. This is in a linear distribution. This is in a focal distribution, but you see the same thing, which is kind of almost like little rims of enhancement with central loss of signal or lack of signal. That's the abnormal disease duct, and it's the periductal tissue that actually is enhancing. This is classic for ductal carcinoma in situ. This is a BI-RADS 5. This warrants a biopsy. Almost looks like a little string of pearls here. So quite, when you see this, very suspicious. All right, then finally we talk about kinetics. So this is a sort of a little bit of a controversial topic of discussion in general, and the idea behind kinetics, because remember, for a full protocol MRI, we have multiple time points that we image after contrast enhancement. So the idea was this is going to be so helpful because, you know, cancers have abnormal vessels that are very irregular. Cancers in the body tend to wash in very quickly, take up contrast or take up blood flow, and wash out very quickly. So when you see kinetics that show quick wash in and wash out, it's definitely a cancer. When you don't see that, it's definitely not a cancer. Unfortunately, that did not pan out to be true. Lots of benign things can show wash in and wash out. Lots of malignancies can actually have very slow, persistent enhancement. And so these are the phases that we talk about, and it's still required to actually, if you are going to talk about kinetics, this is how you should describe it. And that is, how does it enhance on the very first initial phase? Very quickly, does it enhance? Medium versus slow? And then what happens afterwards? Does it continue to persistently enhance over multiple serial time points? Does it kind of stop and plateau? Or does it actually lose signal and wash out? And those are the three curves. So although, as I mentioned, it has currently no statistically significant association with benignity or malignancy, I'll tell you, lymph nodes, wash in and wash out, they have that type 3 kinetic curve. Lobular cancer in particular tend to have very slow initial phase of enhancement and very persistent enhancement over time. In fact, sometimes they are missed if you don't look at the very last post-contrast sequence. So kinetics really shouldn't sway you one way or the other. The exception to that is now with ultra-fast MRIs that are obtained very administration and are somewhat investigational, but now being more and more utilized, that very early initial phase of enhancement that can be appreciated with ultra-fast scanning, which is done, within a few seconds of injections, actually is statistically significantly associated with malignancy and benignity. So I think there's promise on this frontier, but just not yet. So this is just an example of an interesting case. This is a patient who had a biopsy-proven cancer in the left breast. You see it's an oval mass. I guess you can say it's well circumscribed. It heterogeneously enhances. It's areas of enhancement, not enhancement. This was known, though, biopsy-proven carcinoma, and she presented for extent of disease MRI. We were looking, is there anything anywhere else? And yes, in fact, there is an area of focal non-mass enhancement in the other breast, sitting all by itself. Even though it's T2 hyperintense, it's there by itself, nothing anywhere else. So this should really increase your level of suspicion. And so, because what we would do is you could do a targeted breast ultrasound to see if you can see it under ultrasound, because that would be an easier biopsy should you find it, or go straight to MR guided biopsy. But when you look at the kinetics here, certainly the cancer is washing in and washing out, but this little focus just shows persistent enhancement. So should that sway, the way I'm asking, the answer is no. Should that sway your recommendation for a biopsy? And the answer is no. So by the way, this was persistent type curve, but an MR guided biopsy of this focal area of enhancement, previously known as a focus, is still recommended because morphology trumps kinetics. Number one, it was irregular, which you can appreciate, but also it was unique. It was the only thing in that breast. There was none of those little areas of enhancement in the other breast to dismiss as background parenchyma enhancement. So this needs to be addressed before surgery. And this, in fact, was a small invasive ductal carcinoma on the contralateral side as well. So just remember, morphology always trumps kinetics and trumps stability, as a matter of fact. So that's sort of that's the whirlwind through breast MRI.
Катерина, у нас в чате есть вопросы.
Okay. Can we rely solely on the diffusion coefficient in breast MRI to differentiate between? No. That's a great question. The answer is that it's still evolving. I think it is helpful. It is not being used yet consistently, and data is still coming, but I would not use solely. I would use morphology, which includes enhancement so shape, distribution, depending on what we're talking about, margin, and enhancement. Morphology should be number one. Why are brain ADCs not breast MRI, and should we develop breast specific diffusion analysis? Yes, and yes, and yes. It is being developed. It's a fantastic question. And I think that as we get better at it, maybe with the help of AI, and we can actually show consistent association with malignancy and benignity, maybe we'll be able to obviate the need for contrast in breast MRI. I don't know, but that's sort of certainly the hope. And it is coming and it's being worked on. It's just, we're not there yet. In patients with breast implants, how can silicone-induced lymphadenopathy be differentiated from metastatic lymph nodes? Yeah, that's a great question. having, so when you image implants, if there's any question, we usually, when we have silicone implants, regardless of what the patient's coming in for, if she's having an MRI, we throw on dedicated silicone sensitive and silicone suppressed images. So if a lymph node is suppresses on silicone suppression images, is just, silicone laden lymph node, and you can dismiss it. So that is a very helpful problem solving sequence to have if you're questioning potentially, silicone rupture, silicone laden lymph nodes. And then additionally, how should staging be approached when MRI findings are inconclusive? Is unclear whether percent metastasis or okay. So again, you can make the recommendation to, so if you see morphologically abnormal lymph nodes, if silicone specific sequences, let's say it wasn't done, it wasn't known, you can recommend an ultrasound, because you'll see that snowstorm appearance on an ultrasound of a silicone laden node. And so that would be helpful. If there's any question ever, then absolutely err on the side of biopsy, because that will help your surgeon, certainly. But silicone can be appreciated both on MR and on ultrasound quite easily, definitively so. In general, obviously that is associated with rupture. So you should see extracapsular rupture to see silicone laden lymph nodes, or a prior rupture. And let's say her implants are now replaced. But having that history is helpful. Your staging and the information you provide on MRI for extent of disease is very helpful to surgeons, because remember, on a mammogram, surgeons may not be able to appreciate on physical exam, even if it's just level 3 lymph nodes, and importantly, the internal mammary nodes, which actually change staging and also inform the field of radiation treatment. So the information you provide is very helpful. So when I look at extent of disease, things that I report is, the size of the mass, the cancer in 3 dimensions. That's helpful for them. And I actually say, anterior, posterior, transverse, and craniocaudal, because the surgeon, it helps them to know and plan their approach. It's distance from the nipple, because that actually has a bearing on whether the nipple is involved. If it's less than 2 centimeters, it's more likely to be involved than not. So if they're considering mastectomy, they will take the nipple if it's less than 2 centimeters. I talk about distance to the skin and pectoralis muscle. We talk about lymph nodes, whether they looking at internal mammary as well as axillary, and talk about how many abnormal nodes there are, because that again will differentiate the patient from sentinel lymph node biopsy versus a full axillary dissection. And then what stations, 1, 2, or 3. What else for staging? I think that's pretty much it. And then in patients with multiple small cysts and marked background parenchyma enhancement on MRI, does ultrasound provide? I would say no. It's a good question. So train your eyes and look for symmetry and bilaterality. So if you see something that is different and unique, even if it's 1 and 1 in each breast, as I showed you, that should raise your concern. In fact, in a patient with multiple cysts and multiple masses, on ultrasound, you're going to see a bunch of the same things that you are either following unnecessarily with BI-RADS 3 or biopsying. So it actually is not going to be very helpful. MRI is still, even despite marked background parenchyma enhancement, is the most sensitive exam. And again, it just takes time and seeing a large number of scans and training yourselves to look for understanding the history, understanding the patterns of background parenchyma enhancement, and always look for uniqueness and morphology that would be potentially suspicious. But it's a great question. And if I do see something on MRI that I deem suspicious, as the case that I showed you, I may recommend an ultrasound, because if I see a sonographic correlate, now knowing where to look, and we call it an MR directed ultrasound, not second look anymore, because maybe she didn't have a first look, but an ultrasound guided biopsy is just easier. But it depends what, right? So a mass, I would take the time to look for with an ultrasound, because maybe it was missed before, if it wasn't, or maybe it wasn't done. Non-mass enhancement, you will not see with an ultrasound because it's usually DCIS. And if she had a recent mammogram that was negative, no abnormal calcifications, then just go straight to MR guided biopsy. And also remember, if you see something, give an MRI, and we didn't talk about BI-RADS assessment, but breast MRI should never have a BI-RADS 0 unless it was non-diagnostic. So let's say you injected contrast and it extravasated. That's a non-diagnostic for breast cancer MRI, or she moved so much you can't see it and you say, come back. Otherwise, you don't want the other person, if you're recommending additional imaging like an ultrasound or mammogram, you want to then also say, what do you recommend if that imaging doesn't show anything? Because you don't want the other doctor who's looking at the ultrasound potentially or a mammogram to reinterpret your MRI, right? So if I see a mass and it's irregular, with a thick rim enhancement, I would recommend a MR-directed ultrasound. I would say that MR-directed ultrasound is recommended. If sonographically occult, MR-guided biopsy is recommended, and give it a BI-RADS 4 or 5. If I see an oval, well-circumscribed T2 hyperintense homogeneously enhancing mass, I would recommend a second or MRI-directed ultrasound and say, if sonographically occult, 6-month follow-up MRI can be done and give it a BI-RADS 3. So you should always give a BI-RADS. If there's no contrast, if an MRI is being done just for implant evaluation, no BI-RADS should be given because BI-RADS is just breast malignancy. So just do not, NA, not applicable is the recommendation. Usually we combine the two, but if there was no contrast, if it was not given, no BI-RADS should be given. Patients with multiple small, okay, we answered that. Okay.
There is also one comment in the chat section about the latest digital version of the BI-RADS 2025. I guess the previous one.
Oh, do you happen to have the latest digital? I don't, unfortunately. So it was interesting because the American College of Radiology now is tying it to each individual password and account. So what we ended up doing so that we all have access, we bought the physical books. So we don't have any digital copies, but it is available on the American College of Radiology, the ACR. It can be bought, I think it's $600, but the problem is the electronic is tied to the account of the person who buys it, so you cannot share it. Yeah, I know. They're just trying to make money. Very frustrating. Previously it was available. I have the old one, but that doesn't help anybody. If there are any questions anytime and I can be helpful, my email is in the lecture. I'm going to put it again in the chat. Feel free to reach out to me anytime with anything. I'm always happy to chat, to talk, to answer any questions. And if I can be helpful in any way, I'm happy to do so.
Спасибо большое за лекцию. Мы хотели бы от лица всей азиатской школы онкологической визуализации поблагодарить за ваш труд, за ваши старания, за уделенное нам время. Эти лекции были очень полезными, они были very comprehensive. Я думаю, что они были очень-очень полезными для нас, для всех маммордиологов наших стран. И еще, пользуясь случаем, я бы хотела вслух озвучить наше приглашение. Этим летом в июне и в начале июля с 29 по 2 июля будет проходить азиатская школа онкологической визуализации. В Алмате мы бы хотели пригласить вас как спикера. Первый день будет 29 июня. Если бы вы могли приехать и очно провести обучение для всех молодых и не очень молодых маммордиологов наших стран, we would appreciate it a lot. That would mean like
Спасибо огромное за приглашение. Я пытаюсь, чтобы получилось со временем, потому что обычно летом у нас просто не хватает людей, и поэтому очень тяжело уехать. Но
Катерина, Алмата летом? это must
Я
see.
слышала.
Это очень красиво. Там горы. Мы устроим вам такую культурную программу. Вам понравится. Там такая вкусная кухня. Вот честно, мы будем очень-очень рады видеть вас. И я думаю, что we will keep in touch. Может, и если у вас получится, то хотя бы на вот несколько дней, сколько вы сможете уделить, это было бы просто очень-очень хорошо. Мы показали вам, как мы здесь. Еще у меня был один такой практический вопрос, потому что на самом деле я сама не занимаюсь интерпретацией МРТ молочных желез, я занимаюсь вот контрастной маммографией. Насколько я помню, вот в стандартах, да, по МРТ молочных желез USA написано, что, то есть там вот все эти sequences написаны, и написано, что только в том учреждении, если у вас есть возможность провести МРТ под МРТ guided biopsy, или у вас есть референс-центр, куда вы знаете, что вы направите. Ну, как я уже говорила в прошлый раз, что у нас нету в нашей стране, во всяком случае, у нас нет MR-guided biopsies, насколько мы вправе, насколько, не то, что вправе, да, но то есть насколько вообще вот это практично МРТ, то есть и что нам делать?
Очень хороший вопрос, я отвечу на английском. In the beginning, we still did MRI before MR-guided biopsy was available. So I think it's still reasonable, but because you have contrast-enhanced mammography and you have contrast-enhanced mammography guided biopsy,
we do not.
Oh, you don't? Oh,
no.
Okay. Well, then do either one. Yeah, whichever one you can do. Contrast-enhanced mammography, we don't have, I know my colleague, Dr. Coffey, gave a talk as well. We don't have a lot of studies, but the studies that we do have show it's almost as good as MR. So definitely go with what's available, meaning, if there are some centers and you can offer MRI, do it. If you have to prioritize which patients, give it to the ones that are highest risk, very high risk, like BRCA1, BRCA2, and for extent of disease MRI, the ones that have newly diagnosed breast cancer, and you're looking to see so you can really guide the surgeon, because that can give them the extent. So that even without MR-guided biopsy, that could be very helpful for your surgeons to tell them what the extent is, where to go, what's the actual involvement, because that's your most sensitive exam. But you have to balance resources with what's available. Hopefully, eventually, more centers will open up, and then you'll be able to provide access to MRI as well.
Yeah, fingers crossed.
Yes, yeah. But contrast enhanced is just as almost as good. So. Yeah.
Спасибо большое, доктор Катерина. Спасибо большое, уважаемые коллеги, за то, что вы уделили нам сегодня свое время. И я думаю, что мы все встретимся либо в Алмате, hopefully, либо на следующих наших вебинарах в рамках нашей азиатской школы визуализации. Спасибо большое. Всем хорошего вечера.
Вам спасибо большое. Спасибо за приглашение.
До свидания. Keep in touch. See you.